Hi, everyone. Welcome back in Health AI Institute's and the roundtable on patient safety and the AI. And I hand over to Gopal and who will moderate the session today.
Thank you, Ikram, and a hearty welcome to Dr. Tejal Gandhi, as well as to all of the guests who have been able to join us right here in Minnesota, in the country, and overseas. So thank you all for joining us, and we're pleased to bring to you today a very important topic, patient safety. It is something that has eluded the healthcare sector for the longest time, and for a variety of reasons, there are errors, and at the same time, even one error is one too many. And if I have the numbers right, about 250,000 people die each year, at least in the United States, as a result of medical errors. But I won't get into that. Right now, the opportunity we have is to talk about artificial intelligence, because that will totally redesign or have an impact across all the domains within healthcare. But if we can drill down a little bit more on patient safety, as to how we can improve patient safety for the American people, would be something that we want to learn and take it from here. Dr. Tejal Gandhi is a preeminent leader in the patient safety space. She specializes in artificial intelligence, has done a lot of work in this domain. Her background is absolutely as illustrious as it can be, and it's all posted, so you can see her background. So we can take full advantage of her time here with us. Let me go directly to Dr. Gandhi and say, Tejal, please take it from here. And what we will do, by the way, Tejal, is once you've done your presentation, we will open the floor for virtual floor for Q&A, and we'll talk about, and people will have questions. I have asked my colleague Ikram Khan to field all the questions. So during the presentation, please feel free to submit your questions, and we'll be addressing them at the end of the presentation. So Tejal, please take it from here.
Thanks so much, Gopal, and very happy to join you all today. And so, yes, I am going to talk about patient safety and particularly how we can use artificial intelligence to improve safety, and both the risks and the opportunities that I think AI will bring to the field. Let's see here. So, as I'm sure many of the folks on the webinar know, there was an executive order around artificial intelligence that came from the White House. And in this executive order, they very much highlighted guiding principles, but also industries where this was going to be particularly important. And as you can see there in that first bullet, many sectors where AI is going to be leveraged, but healthcare is right there highlighted, because the opportunities in healthcare are immense. And there have been a lot of groups really working on how do we really think about implementation of AI in healthcare, and what are the key, again, guiding principles to make sure that we're doing it in a trustworthy way. And you see these various elements: privacy and security, equity, usefulness, accountability and transparency. But safety is one of the fundamental principles when we think about implementation of AI. And so when I think about that safety bubble in implementation, there are some key questions that I think we need to ask. And there will be a fourth one that you'll see in a moment, but I'll start with these three. So first, I think about, is the technology designed to be safe? Is the technology implemented safely? And then is it being used safely? And the reason that these questions come to mind for me is I think back to electronic medical records, where we have had many challenges with the design of electronic medical records, with the implementation, and with how they're being used, and issues like workarounds and people not really using the technology as intended. So, one of the areas that I've been thinking a lot about is, what are the lessons from electronic medical record implementation that we need to make sure we learn from as we're moving forward with AI implementation on top of those electronic medical records? So design, implementation, and use are all going to be key questions to be asking. Now, a lot of organizations are really starting to think about those questions and think about how do they oversee implementation of these AI tools? What governance is most effective, et cetera? And this is just one example. There's been several papers that have come out that have really highlighted how, particularly in larger health systems, they are thinking about governance, and they're having these centralized groups that will look through some of those criteria that I just listed. This one comes from Duke University, and they're looking at what is the clinical value and safety? Are there any issues around equity, usability, and adoption? That gets into the both design and also is it going to get used in the appropriate ways? Regulatory compliance, transparency and accountability, et cetera. So they have a whole set of criteria that they are looking through as they are evaluating different tools to bring into their health system. Also, another example from the Duke Health System is this issue of, again, implementation and particularly use. So this was an example around large language models that they were allowing or are allowing their clinicians to use, but they decided to create principles of appropriate use, how you should and should not use large language models in the clinical context. And they created these and have done training to their clinicians on these principles to make sure, which it's still not 100% obviously, but at least to have some guidance to their employees about how to use large language models. And, I think this is, again, an example of maybe some of the ways that we didn't do so well with electronic medical records in terms of having some very clear guidance around how you should or shouldn't use some of these tools. And then there's been many experts that have really talked about the importance of having guidelines for safe AI implementation, and importantly, to be able to monitor AI for safety risks. You can't just implement and then forget about it. There has to be this constant monitoring, measuring of whether it's having the impact that you're hoping for, et cetera. And they talked about in this paper, particularly processes for AI traceability. So to even know when AI was involved in a particular clinical episode so that if there's an issue, you can understand the contribution of AI. So those were recommendations of this particular paper when thinking about those guidelines for safe AI implementation. So that's actually less what I'm going to talk about today, but I wanted to at least start with it to say there's a lot of work that we have to do on this sort of, maybe it feels a little less exciting, but it's really critical of how do we really ensure that the technology is going to be designed and implemented and used safely. But the question that I've been particularly interested in on top of that is, can the technology actually improve patient safety? And so when we talk about patient safety, we are talking about preventable harm as a result of medical errors. And, Gopal mentioned some of the statistics, 250,000 people die each year from medical error, according to one study at least. And, it's been named as the third leading cause of death in the United States. Issues are occurring in all healthcare settings across the entire continuum of care in terms of medical error. And we have been working on patient safety since 1999, when To Err Is Human came out from the Institute of Medicine. And so that's over 25 years. We have made some progress in reducing harm. And, I have actually written some papers about the fact that, here's all the places that we have made some progress. However, we have a long way to go, and many of the recent studies really haven't shown a lot of improvement in some of our key measures of patient safety. And so the field, I think, is really taking a pause right now and saying, okay, 25 years in, we've made some improvements, but we still have a lot of harm that's still occurring. Things like medication errors, diagnostic errors, falls with injury, wrong side surgeries. I mean, you name it, a lot of these things are still happening. So what can we do in addition to the work we've already been doing? What can we do to really accelerate our progress? And AI comes up over and over again now in conversations as a new direction to help solve some of these very intractable problems. So I'll give you a case just to start off. So this is actually my daughter who had a fall while roller skating, and she fell and hit her wrist on the ground, and she was complaining of wrist pain. So took her into the pediatrician, who got an x-ray, and the reading was no fracture. So we just put her in this little brace and said, "You're fine. It's just a bruise." And about 4 or 5 days later, she was still complaining of significant pain. So went back to the pediatrician. The pediatrician sent us to an orthopedic expert who re-looked at the films and identified that there was a fracture. So this was a missed and delayed diagnosis of a fracture. Now, it was a subtle finding. So, we know to err is human. Human beings will make mistakes. It required a specialist to identify that there was a fracture. Maybe it's not even realistic that a non-specialist would have found it, but this is medical error and harm from a missed and delayed diagnosis. And so, how do we prevent these kinds of errors, I think, is exactly where tools like AI can start to come and become a huge value add in the diagnostic process. So there have been researchers who have done literature reviews of all of the issues in patient safety and where artificial intelligence maybe has the most potential. This review talked about these particular patient safety domains and the likelihood of impact. And really, if you look at likelihood of impact, the majority of use cases are around prediction models. So can you predict who might be at risk for an adverse drug event or sepsis or a fall or a pressure injury, decompensation? A lot of the examples relate to this prediction capability. But there are other areas, particularly diagnostic error, like I just highlighted with that case, where there are significant opportunities as well. And it's key to really, as you're thinking about prediction models and in particular, really key to also think about how do we tie that into clinician workflow and drive action. And so the reason I say this is because we've had prediction tools for a long time. And one of the challenges has been, for example, we've had prediction tools about risk of readmission, and everyone's trying to reduce readmissions. And we've had tools to say this patient is at high risk for readmission, and maybe even alerting the physician that this patient is at high risk for readmission. But that doesn't really help the clinician know what action to take to actually reduce that risk. And so what we really need to do is say, this patient is at risk for X, and this is the Y action that you should then take to reduce that risk. And so I think that's where with AI, we can maybe take these prediction tools to the next level by tying it into the workflow. So it's there in the moment in time when it's most useful, and tying it into recommendations around actions to take. Another interesting opportunity with AI and patient safety is in the area of decreasing cognitive burden. We know that cognitive load, burnout, these types of things can impact clinicians' ability to make good decisions, can impact their ability to come to the right diagnosis, et cetera. And so if we can reduce cognitive burden on our clinicians, they will have more mental capacity to actually focus on the task at hand, whether it's the patient in front of them or reviewing a complex history to determine what their next course of action is going to be, et cetera. And so there are lots of ways that AI can reduce cognitive burden. In this paper that I actually wrote with some colleagues, we lumped it into these categories of data gathering, data synthesis, documentation, taking appropriate action, and structuring asynchronous activities. So these are all places where AI can actually help with these functions and reduce the burden on the cognitive burden on the clinicians. So, data gathering, I think, is an obvious one where right now, actually a colleague of mine sent a note out to us saying to review a patient's chart before a visit in the ambulatory setting with all the notes, all the documentation, everything in that electronic medical record. It is the equivalent of reading a novel like Fahrenheit 451 before every clinic visit. So we know that's impossible for a human being to do, but it's not impossible for AI to do in terms of gathering the data from all these places in the electronic health record, and then performing that data synthesis. Can it put it together in a very short summary that then I don't have to spend 10 minutes looking through the chart looking for that particular piece of information that I need. So I think the gathering and synthesis pieces are going to be really important. And you just think about the time that can hopefully be retrieved, that you don't have to spend hunting and gathering and synthesizing, that then you can use for your interactions with patients or for thinking. And then there's other areas as well, making documentation much easier. We know documentation burden is a huge burden for clinicians. And then I talked earlier also about taking appropriate action, et cetera. So there's a lot of different ways that AI can help with reducing that cognitive load. And this was another paper that came out that talks about artificial intelligence in the primary care setting. And I highlight this because we often think about patient safety as a hospital issue, but patient safety is an issue across the entire continuum of care, including in the ambulatory setting. Issues like cognitive load and cognitive burden actually are huge issues in the primary care setting. I mean, I live in Boston, and in the news just in the last couple of weeks has been primary care doctors who have decided to unionize because they don't feel like they can perform their jobs as needed, given the time constraints that they're being asked to work in because of all the work that they need to do in a 15-minute visit. So things like AI might streamline and help their ability to be able to do their jobs in a more effective way and reduce burnout. So in the primary care setting, there's a few use cases, and they tie into some of the themes that I've already touched on. So one is inbox management. So, you could really prioritize patient messages that are coming in through patient portals, help with generating draft responses, so helping with that documentation piece, and optimize the communication, including for literacy appropriateness, which thinking about engaging patients and making sure patients understand what we're saying, et cetera, those tools could be really helpful. There was a very interesting study, I'm sure many of you have seen it, around this issue of documentation and helping doctors be able to craft responses on the portal, for example. This was a study that was not in a patient portal, but was looking at a public social media forum where physicians versus a chatbot were responding to patient questions on a public social media forum. And it was found that the chatbot had longer responses and more empathy compared to doctors. And so, this got a lot of media attention of like, oh, the computer has more empathy than the human. And I think that's not really the way to look at this, but it's more that, when physicians are responding to hundreds of messages they're getting, they have to be very efficient. And that means they may not be able to be as empathetic as a chatbot that has all the time in the world to draft these responses. And so I think, there's opportunities here to help with that workload and potentially have more robust communication with our patients. I talked about clinician documentation also as a major potential benefit. And this is really the exciting, the thing that is exciting people the most these days is ambient artificial intelligence. And so if you talk to health systems about what technology around AI that is top of their list, the ambient scribes are one of the things that organizations are actively implementing the most. And this would basically be in particularly primary care settings, but other settings as well, where AI is listening to the visit and turning that into a clinical note. And it's not just a transcription, but it's really a synthesized note. And in this particular study, they found a significant larger decrease in time spent in the electronic health record outside working hours among users who were using ambient AI scribes compared to those who did not. So it reduced the documentation time and helped primary care doctors, in this case, not be documenting, at 11 o'clock at night after everybody else in the family's gone to bed, which is what a lot of my primary care colleagues say they end up having to do in the current situation. Another really interesting use case for primary care is between visit panel management, and this ties into the diagnostic error arena again, so a missed and delayed diagnosis. There's a lot of things that can be done between visits. And, that 15-minute visit, as I said, that time is so valuable, but could we just design AI tools to find things that need to be done between visit, whether it's getting cancer screening done or making sure an abnormal test result gets followed up, or all sorts of things that could be used to optimize time between visits, and then hopefully have that 15 minutes be focused on more of the things that need to be done in a one-on-one interaction. So ultimately, as I've thought about all these studies that are coming out about these use cases and how, knowing all the challenges of patient safety over the last 25 years, I've really been thinking about, okay, what are the top areas for patient safety with this tool? And, top of that list, I've already spent some time on it, is that automation of low priority or low difficulty tasks, like, decreasing administrative burden and improving cognitive load. So I think that's really top of the list. The ambient scribes and other tools like that will help with that. In patient safety in particular, I think the area of diagnosis has so much opportunity. When you look at my daughter's case, I mean, there are tools now in imaging with radiology where the AI can help identify some of these subtle findings that a human being may be at high risk of missing. And so I think imaging has been one of the top areas for implementation of AI, but there's many other opportunities in the area of diagnosis, like following up of test results, following up of complaints that didn't get the appropriate follow-up, synthesis of information so I can easily find the history of a certain complaint, make sure I'm not missing something, et cetera. So, diagnosis, I should say, missed and delayed diagnosis is probably one of the least well captured areas in patient safety, and has been one of the most challenging to address. So I think this is definitely at the top of my list. Another important area is medication safety. Medication safety and medication errors still are coming through as one of the most common types of patient safety issues in the inpatient and outpatient setting. And so being able to use even better decision support to identify medication discrepancies, synthesize information, et cetera, is going to help with medication safety. I mentioned again the prediction component, that there's going to be a lot of opportunity around predicting patients at risk of safety issues like deterioration, like falls, et cetera. I'll skip this next one and come back to it in a moment. Patient engagement, I think, is a big opportunity as well, because, as I mentioned, we can communicate perhaps more effectively with some of these tools. And then measurement, I think, is one of the, and I say measurement here, but it's really measurement and learning, where I think we have a big opportunity as well. So we can, I think, leverage AI to be better able to find safety issues in electronic medical records, which currently we struggle to do. Currently, we rely on human beings reporting when errors occur, which generally is 5 to 10% of the harm that's out there. And we know there's a lot more harm that we could identify potentially using AI. And to analyze the reports that are coming in, most health systems get thousands of safety events reported to them every year, and they struggle with that volume and really finding themes and trends and underlying causes and all of those kinds of things. And I think AI could really provide some tools for us to be more effective in how we learn and improve in safety as well. So, I think about it as improving safety issues like diagnosis or medication errors, but also improving how we learn about safety and improve safety through some of these tools. So that was all very positive about all the great things that AI can do for us in patient safety, but we should also make sure that we really think about the risks and what do we need to worry about. And some of this ties back to what I started with, is we have to make sure it's designed safely. And there's been much discussion about bias in AI, about perpetuating inaccurate information in the electronic health record, about hallucinations, and in the implementation, lots of concerns as well of, again, bias in how it's being used. Is it generalizable? Is an algorithm developed at a big academic medical center going to work in a small rural hospital? Is it going to widen the equity gap because, more wealthy hospitals and health systems can purchase these tools and others cannot? Will it depersonalize care? So many concerns around implementation. And then there's this whole area around even the impacts it will have on our clinicians. So how does it impact cognition? Are there skills that our clinicians will lose that we think they need to have? Are there new skills that they need to actually learn to be able to use the AI safely? So are there new competencies that clinicians need? So many questions right now around some of these impacts on our clinicians and how to sort of maximize their ability to use these tools effectively. In the sort of de-skilling and reskilling categories, there's been this concern about if you rely too much on the AI, you might lose your clinical judgment and your clinical skills. And if the AI tool says the patient is not deteriorating, but you feel like something's going wrong, will you just trust the AI and not trust your own clinical judgment, for example? And this has been a concern for years, even with electronic medical records and computerized physician order entry. There were all these concerns about, oh, if we implement these, our clinicians won't remember drug interactions anymore because the technology just shows you drug interactions. And it turns out that really wasn't a big deal for the clinicians to lose that knowledge, because now it's so readily available in the technology and it's more effective if it's in the technology. So, we're going to have to sort through, are these concerns true concerns or not? And then I mentioned again, reskilling. How do we really teach about what algorithms can and cannot do? How do we highlight areas where the algorithm may be less certain? Because it always seems very black and white, but maybe it's less certain and we need to highlight that somehow. How do we teach clinicians how to effectively oversee, and how do we talk to patients about it? And that third bullet, I think, is really important, because any AI developer or technology person that I've talked to about risks has said, well, AI is the co-pilot. There's always a human being that has to oversee it and make sure that, there's agreement on what to do, et cetera. But human beings are not particularly good at that kind of oversight. We have many examples where, you ask clinicians to review a note that was drafted by even a dictation service back in the day, and most of the errors make it through. They aren't caught by clinicians who are reviewing the notes. So relying on humans to effectively oversee the AI may not be the most robust safety strategy. And this has been written about a lot, including this paper, which I really liked, which talked about, okay, if you are going to ask clinicians to oversee, maybe there's ways to actually make clinicians better able to do that oversight. And they provided some strategies around how to do that. So this is a very evolving area that I think we're going to need to learn a lot about. So lastly, what do patients or the public think about AI? This was a survey from the Pew Research Center from 2022. Fewer than half in the US expect artificial intelligence in health and medicine to improve patient outcomes, which is interesting. So not high expectations necessarily around improving patient outcomes, though still, 40% still thought it might lead to better outcomes. So even though it's fewer than half, it's not a small number or small percentage. But when you think about it more from the patient safety lens, Americans really tilt positive on AI's ability to reduce medical errors. They 40% or so thought it would make medical errors or the number of mistakes made better. Though interestingly, there was greater concern around data security and on that personal relationship with their healthcare provider. So, many of you have seen this Gartner technology hype cycle, and I think we are probably with AI in healthcare, and maybe even AI in patient safety, if I get more specific. I think we're kind of at that peak of inflated expectations. I mean, I do think there's real opportunity. I think we have to really understand those risks so that maybe we can reduce the trough of disillusionment. And so hopefully we won't drop so deep into a trough, and we're going to get to that plateau of productivity sooner than we have with some other tools like electronic medical records, actually. Hopefully we can get to that plateau of productivity much more quickly. So how to go forward with AI and patient safety? I think we have to also remember not to hold AI to impossible standards. Perfection is not necessarily the goal because our current system is not perfect. We have a lot of medical errors happening. So we just have to be better than the current as opposed to perfect. I think that's really important to think about. We need transparency and governance and oversight. We can't be afraid. AI is mainly going to help, hopefully, with the easy and boring stuff to offload that so that we can spend our time on the things that really matter. And hopefully AI will help us solve the common problems that have been challenging. And so we can think of AI as a new team member who's thoughtful, intelligent, able to do some things very well and others not so well. And we need to really proactively assess and monitor safety implications on many levels. And I've sort of highlighted many of those levels here. And the question is, when will we feel unsafe if we are not using AI? And as I talk to colleagues around the country, that time is really now. If we're not using AI in certain areas, I would say imaging, for example, is one of those areas, we are less safe than if we are using AI. So, as we go forward, AI is here, and we just have to figure out how we're going to optimize it. So with that, I am going to stop sharing, and Gopal, I'll pass it back to you because I'm sure you have lots of questions that you and others have been asking.
Yes, Tejal, indeed. First of all, let me compliment you for this outstanding presentation. It brings together a lot of pieces, what's happening, what you expect as risks, and what are the future possibilities. And of course, as AI evolves and develops itself, I'm sure there'll be a lot of unknowns as well. There are a lot of things we know and we are anticipating, but we have to be prepared for things that'll just happen, good, bad, and ugly. So let me ask you first question. We had this executive order with the change in administration. Do you see changes happening? What's your sense about from a policy point of view?
I mean, okay, so I will full disclosure. I mean, I am not, tightly linked with those who made this executive order or with government right now, but I feel like with the new administration that is very pro business and pro industry, I mean, I think these solutions are just going to thrive even more. I do think whoever's there in the administration knows also that we have to have safeguards. I mean, yes. I don't think that's going to change as well. And we have, agencies like ONC and FDA and CMS and others that are really thinking about those safeguards, Joint Commission, et cetera. So I guess I don't necessarily see a sudden change in trajectory. We're on this upward trajectory, and I think that's just going to continue.
So for the audience, basically, we can expect this balancing act between guardrails and governance and opening for innovation, because there'll be a lot of data flowing into the system, which brings me to the next question. EMR, EHRs have been at the heart and soul of the data, right? Now you have social determinants of health data, which has never been part of looking at the patient holistically. We talk about whole person care. And now with AI, you have the possibility of drawing upon all the other data, which was never available beyond social determinants of health. Having said that, what kind of effort are you seeing in the industry with a complete change in paradigm? And maybe my question is, are these institutions, healthcare delivery systems, looking at an overarching strategy, or are they just scrambling with, okay, let's apply AI tool here or in another scenario? Is there a strategy effort going on?
I think it's both and I also think it's like how advanced the organization is and resourced, et cetera. So, I mean, I think a lot of organizations are thinking about it to like solve specific problems. Like, we can use it in radiology for this, or we can use it in primary care for that. But I do think there's also this push to really think about the data integration challenge that we've had for a long time. And, how can we bring a lot of data sources together and understand what we can learn from doing that. And, the examples around, predicting risk of patient safety issues or sepsis or those kinds of things are some examples of that. But I think so every large health system that I've talked to, is thinking about how do we bring all our data together so we can do integrated analytics and bring together these data streams that have been very traditionally siloed and start to get insights across. And, Press Ganey, where I work, that's one of our big focus areas is we have data on patient safety, we have data on workforce engagement and burnout, we have data on patient experience, member experience, but they've, normally, traditionally in health systems, those have been relatively siloed, yet we know there's interconnections. So I had done a analysis of, if a patient doesn't feel safe, then their patient experience, outcome score really drops. So like the connection of safety and experience is very strong, but no one had actually brought those two data sources together to show that connection. And so that's so our strategy is understanding these interconnections. And I think health systems are really gravitating to that as well, that they need to take their existing data and integrate it so they can really find cross-cutting patterns and themes that will drive interventions. Now, I say that, I also think there's opportunity to think about entirely new sources of data, right? So, you could pull in device data, you could pull in data around patient census and acuity and staffing. You could pull in, I mean, some organizations have started to pull in weather data because they know that, when it's a heat wave, certain things happen, et cetera. And so there's all these additional data sources that I think over time we're going to want to pull in, but we haven't been able to do it really because they've been siloed, but also we didn't have the analytics tools to really think about all of these things together. And now I think we're moving in that direction.
So you see now, of course, delivery systems, the ones that are big ones that are well funded would have an obvious advantage because they'll be able to do a data strategy, they'll be able to look at tools, they'll be able to look at various ways of implementing, right? And even skilling up. So coming to the workforce part of it that you talk about, skilling and de-skilling, right? Is it simply a clinician piece, or is it a larger all of staff situation? What are you seeing?
I think it's going to have to be more than just the clinical staff. Gotcha. Certainly, if you think about leadership has to really understand what the potential and implications are. But even, there's probably folks in, finance and, certainly technology, et cetera, like other parts of the health system that are going to need to understand these tools. If you even think about, clinicians broadly, it's not just doctors, right? Doctors and certainly nurses and pharmacists and even social workers, you talked about social determinants and all that stuff. So, I mean, it is a whole new area of skill that needs to happen, of skilling that needs to happen. And I mean, you touched on a point probably one of the areas I'm most worried about is this issue of inequity, not so much of the algorithms, because I know everyone's worried like, oh, algorithms will perpetuate bias, but I think we're getting pretty good at understanding that and hopefully designing the algorithm to not have bias built into it or perpetuate it. But the issue of the haves and have-nots, right? Because you've got the large health system that can maybe do some skilling, can invest in these tools, can bring data sources together. But I worry a lot about smaller, less well-funded places, and even for them to have the governance and the skill for the governance of knowing what tools to bring in is just going to be challenging. And so that's where I am concerned. I do think there's going to be, partners, and I think of us as one, but there's many others who are like going to do a lot of the work and then hopefully can just provide it, as opposed to these organizations having to build it themselves. But I was at a conference on safety and AI, and this issue of the haves and have-nots was a very big theme, because everyone's kind of worried about that dichotomy happening or widening.
Now, when we talk about patient safety, originally it was mostly in the in-hospital care situation, then ambulatory care. Now, a lot of care is moving into in-home care as well. Would that increase medical errors or patient safety issues?
I mean, it's interesting because it's been studied thus far, hospital at home, for example, they've looked at safety outcomes and clinical outcomes, and they feel like patients do better when they're at home.
At home, yeah.
I do have, I worry about it a lot in terms of even caregiver burden and other things, but the studies have shown that patients, if they're selected appropriately, can do better. And I think that we have tools coming with AI where it will augment how safely we can do it, right? Because we can use video, for example, and be able to monitor even more robustly, and, even know, like, if someone's at risk of falling because of some sort of motions or things like that. Like, there's a lot of things that can be brought, I think, into the home that will actually make care in the home even more safe than it is now. So I think there's a big opportunity there.
And what do you see as the impact of, as you said, data can now be collected from different silos? When I call them silos within the healthcare ecosystem. If you were to take a horizontal approach and say, here are from pharma to payers to providers and everybody, right? Medical devices, etc. And if data integration has been a problem, even in a hospital setting, do you think there's an opportunity to rethink with AI coming into the marketplace? It's a disruptive force. Should the leaders be thinking differently?
Yeah, and I mean, I think one of the big opportunities is, and I say that I should have said this at the start, I am not an AI, expert in terms of the algorithms themselves, but it seems to me, one of our challenges has even been monitoring the patient journey, right? Like, we've been doing it very much by episode, right, as opposed to being able to, here's a patient diagnosed with breast cancer, what is their journey for the whole thing, and where are their risks along the journey, where were their potential opportunities, et cetera. And, like, the insurers have some of the data, the health systems have some of the data, the primary care clinic or the oncology clinic has some of the data, et cetera. But I think these tools will start to allow us to pull things together better. I mean, wouldn't it be nice to be able to say, like, the riskiest time for, a typical patient diagnosed with breast cancer across the next 3 years, their riskiest time is this moment because of this. And, then you can start building tools to mitigate that. But we've just been very episode by episode. That's where I think the data integration, bringing data sources together from the entire continuum across these silos, like I said, because I think the insurers have a lot of this data, but usually that data is completely separate from what, the specialist may see, or the primary care doctor, or even the hospital might have. So, and, there will be barriers to data sharing and all that sort of stuff. But I just think that, I think the payvider organizations are probably going to be the best initial organizations to really try this out, because they may have fewer barriers, given that they're under one big umbrella at the end of the day. Yeah, that's like one example of where I see some of that.
But even coming to the provider setting, right, we have control over the data. It's a controlled environment. Do you think with AI coming in, because there'll be disruption. Of course, there'll be some basics practices that will stay intact. The question is, will they use the business process re-engineering, which has been used very effectively to improve and reach a point of zero defects from a product point of view? So when in the healthcare community we talk about no harm, zero harm, right? How do you see the use of business process re-engineering, the Deming methods, the Juran methods, to improve the process even within the controlled environment? Because new technology is coming in, it's disrupting. So the opportunities to rethink the entire design of the processes. Do you see the leadership?
100%. I mean, part of me thinks we have to do a lot of that work even before we bring the technology in, because sometimes, we had this, it's almost a joke of like, if you have a bad process and then you put technology in, you'll have a faster bad process, right? So some of that needs to be work done before you even bring the technology in. However, I think the technology can absolutely be used also to help think about process optimization and workflows and what are optimal workflows. And then also think about using technology to, we talk about virtual primary care, for example, like,
Right.
just totally changing the primary care workflow process model where, okay, you don't have to see a doctor for certain things. You don't even have to see a nurse. You can do a bunch of stuff virtually, and then it gets escalated at certain moments and so forth. And so, that will change the workflow completely of primary care, I think. And it's needed because of the access issues in primary care. We don't have enough primary care doctors, so we're going to have to do that kind of process redesign. So I think there's a lot of different ways that AI can come in and help with process optimization. But I don't want to skip and let's work on that even before we have the technology, because we haven't done a great job. We have a lot of really bad processes right now that I don't think AI is going to solve all of them.
Yeah, obviously, I agree with you that there has to be some way of at least documenting the as-is, identifying where the processes might be broken or the service delivery supply chain is not optimized. But what are you seeing in the industry happening? Is the leadership, are the board level, the CEO level, or the CFO level thinking differently and saying, "Oh my God, it's time of reckoning. We've got to think differently. We cannot do the business the old-fashioned way." Are you seeing? Because there's also the financial pressure on the industry.
Yeah, no, I think so. And actually, I think that, there's been surveys done. Scottsdale Institute has done some surveys of leaders and what they're using AI for, et cetera. And actually, the use cases that are at top of the list are around workflow and process optimization, because I think of the financial pressures. So that's actually where I think some of the initial investment is happening. I mean, I get all excited about the clinical and safety use case, but I think if you practically look at where hospitals and health systems are investing, it's much more around the process and workflow optimization stuff, because there's a more direct ROI that they can get from that. And actually, I think, I want to say very soon, I didn't see it come out yet, but Scottsdale Institute was going to publish some of their results from the survey they did of hospital leadership and what they're doing with AI and so forth. So that just may be an interesting group to plug in at some point, because they have some very recent survey findings that they'll be releasing.
Well, that'd be an interesting one for us to get. Now, you've gone to many conferences. What kind of conversation are you seeing? Are we seeing conversation at the very early stage, discussing the hype versus reality, or people are scared? What kind of, or maybe the question is, what kind of information they should be having that they're not?
That's a good question. I think I've been going to some conferences where people are very savvy, but that's like, niche conferences around safety and AI or other things where people are very knowledgeable, and they're worried about like some of the things that I talked about in terms of the inequities, or in terms of ongoing monitoring and making sure there's not, degrading performance over time and those kinds of things. But then I talked to organization. So I'm in the safety world, and I talk to safety leaders out there, and I think the conversation there is very different. I mean, they're not as knowledgeable about these tools. So I think there's a lot of just, maybe it's in the skilling category of even understanding what these tools are and what they can and cannot do. For the safety person, for their, optimizing their workflows, et cetera. And then there's certainly a lot of fear, not so much in the safety world maybe, but in general, I know in the nursing community and others around, is this going to take away jobs? Is this, and even, physicians, I talked about reducing cognitive burden and making that things more efficient. And they are worried that means now instead of having to see 30 patients a day, they'll be asked to see 40. And so, which kind of, defeats the whole purpose of, I want them to have more time to do, a better job with their current load. And yet, because we know there's problems with the current load. And so if then they're asked to see more patients, it doesn't really solve the problem. So I think there's a lot of fear from folks that are on the front lines about what this might mean for them practically. But there's also a lot of knowledge that needs to be learned about really what these tools are capable of and so forth. So, I mean, I think there's a whole spectrum of understanding. And even again, at the C-suite level, some people are very advanced and some are asking us to come do very, introductory talks about what AI is.
So the approach we at the Health AI Institute are taking is more of a horizontal approach across all the domains within the healthcare sector, from, again, including payers, providers, and patient safety issues, clinical issues, you name it, medical devices, life sciences, the whole. Are you, what I just heard from you is that, for example, patient safety, you're monitoring what's happening, you're more closely aligned. Is there an appetite or even desire to learn from others, or are you seeing healthcare getting more fragmented? Because everybody would want excellence in their area. So naturally, the focus has to be vertical down. But the larger goal of healthy America will not be achieved unless we see the full continuum.
Oh, I totally agree. I think it's going to depend on the person and what their purview is, for sure. We love silos in healthcare, and we also we want to solve like the specific problem in front of us. I mean, I think that, again, an organization like ours, which is all about collecting data across different dimensions and doing that integration, like we're very interested in thinking about like what are the cutting edge things across the sectors. Mm-hmm. But then there's going to be other folks, if I'm the chair of radiology, I'm going to focus on, my radiology use cases and my specific problems. So, which is fine. I mean, I think you probably need both, right? You need the people that are going to go deep in their area, but then you also need those integrators and more cross-cutting types of groups. And I do think like your head of data strategy at a health system, your chief AI officer at a health system, et cetera, they're like thinking more big picture. And then again, like companies like ours and others that are really thinking broadly across the whole healthcare sector. I'd be curious, on the payer side, for example, how they're thinking about the data integration between health system and member data, because I think that's a really important one to try to break down to for them. But anyway, so I just think it depends on at what level in the organization you're at, whether you're going to be more of that more focused versus generalist, maybe is the term.
So you're saying that right now, and then again, AI is still in early stages, and everybody's trying to figure out, as you said, hey, what will it do for my own particular silo or vertical? But again, we at the Institute have talked a lot about it, and we believe that there has to be coming together of the leadership from across various domains, and they may not at the outset look like if there's a common ground, but I think so. There are a lot of open issues where it'll be very helpful if we can get the leaders coming from various domains. I'm looking at the clock and we just got carried away with a lot of questions. I have more questions, but I'm going to pass it on to Ikram and say, Ikram, you've been fielding some questions. Please go ahead. And I was trying to capture some of them myself, but go ahead, Ikram.
Yeah, Gopal, I've been hearing a lot from you about Tejal, and I've been completely uh, just sitting and listening all the insightful thoughts she has shared, and she covered a lot. And I have a lot of questions for you, Tejal, but I don't think that's we are able to cover it. And I will send you them in the separate mail, and might be able to share those who have posted here. But I'll try to cover one or two, whichever. So the one is that. Definitely with the EHR, we not did that great job. By now we have some learnings from there. So what do you think that's a kind of learning which could be implied when we are thinking of this new technology as AI in the health system? What's your thought on that?
Well, I think there's a bunch of themes that I'll highlight a couple, but there's many. I mean, one is really on the design piece. I mean, I don't think we really thought about usability and human-centered design and workflow optimization and any of that stuff with EHRs. So if we can be much more thoughtful about that and really getting end users involved in design, implementation, et cetera. So that's one. I think thinking through change management in general and sort of how do we get people on board with a change in their process, as we were talking about, or in using these new technologies. I mean, interestingly, I feel like that we're in a very different place, because EHRs, it was like this whole barrier of people who were just used to paper switching to electronic and so forth. But now I feel like we have all this pressure on the flip side of people who want to like just run and implement all this stuff. And we need to slow them down a little with our governance and making sure that we really understand the safety components, et cetera. So it's almost a different challenge, but I think that governance piece is going to be really critical. And we didn't do a great job of that with EHRs initially. I mean, I used to work at a large academic medical center as the director of safety when we were doing EHR stuff. And, every department and division would bring in new tools that they were doing kind of on their own, and they'd have like their separate data set somewhere here and here and here, and there was no oversight. And then eventually that all had to get torn up and it all had to get integrated because it was sort of, all these disparate systems. So governance could be better. And I think that's going to be another big lesson. And then another piece is the monitoring. How are we monitoring over time that these things are performing as intended? Which often the investment in funds is all about implementation, and then it sort of disappears and we don't have those monitoring structures. And that, I mean, in electronic medical records, I remember we had order sets that were getting created all over the hospital, and there was no ongoing oversight of what was in these order sets, whether drugs in them even were still in existence, or whether new protocols had been developed. So then we had to say, all right, annual review of order sets to make sure that these are actually the right things for us to be ordering. But it took us a while to figure out we needed to do that. So let's learn from that and make sure we have the right monitoring processes in place as we go. So I could list a whole bunch of other ones, but those are some examples.
Actually, I would love to get, that's a separate conversation altogether, but I think so, Ikram, you brought up a very valid point that are there lessons learned from the EMR, EHR implementation over the last 10, 15 years, and then how we can do differently.
Well, and I'll say a colleague of mine and I are writing a paper on this very topic, and he has a nice presentation he's put together on the topic. So happy to connect you. Maybe we should
invite him.
Happy to connect you. Okay. It's Dr. Eric Poon at Duke, who we worked at the Brigham for many years, and I know he has a presentation that he can do on it. So if that's something of interest, we're working on a paper, but he has a talk that he could do for you.
Oh my God, our folks audience would love that. We'll take you up on that.
Yeah, just reach out and I'll connect you.
Okay.
I think we are on time, and before closing this, I like to go back to Tejal and hearing her final thought. So if you talk more in the technology word, especially on AI thought leaders, the division on either on the potential and applicability of that AI in general, but other side is a lot of risk and a lot of gloomy thoughts and the ideas is coming on. So we don't know how and which way technology is evolving, and I'm not that expert in that, but neither you. So seeing from a healthcare perspective, you already mentioned that it's good to see them AI as another team member. So what's your final thought, both thinking about risk this technology is going to might put, and also as a beneficiary tool in the healthcare, which is quite inefficient, a lot of death, even though we have good system. But if you see beyond US, much higher potential of that. So what's your final thought before we close the session today?
Well, as I said, I've been working on patient safety a long time and have been frustrated with the pace of change. So I have to say, despite, I definitely am all about making sure we understand risks, but I am very optimistic that there are some challenging things that we have struggled with, like diagnostic error, et cetera, that for the last 25 years, that I think we're going to really see some substantial progress. Even safety measurement, which we've really struggled, we're going to see some substantial progress. So I'm overall, maybe I am on that, heightened expectations curve still. Maybe I'll come crashing down, but I'm excited. Let's just put it that way. So, we have to figure out all the safeguards, but I'm excited.
Great to hear from you. And I will go back to Gopal to hear his final thoughts.
Well, thank you so much. I want to be very respectful of time over here. Tejal, Dr. Gandhi, you've been very generous with the time that you've spent with us. You've given us some new ideas. You've given us a lot to think about. And if it is okay by you, we'll be circling back on maybe in a few months, learn from you what you think is happening in patient safety and across the entire horizon of healthcare ecosystem. And
Sounds great.
would love to see you back again. Thank you so much. And thank you,
Thanks so much
Ikram.
for having me.
Thank you.
Thank you.
Thank you.
Thank you.